Tess King as our first presenter. So Tess, feel free to take it away.
Okay, great. Thanks so much, Courtney. I, like other times, Courtney will hopefully let me know about the chat as things come up. But for those who don't know me, my name is Tess King. I am a third-year resident, and I'm really interested in cancer survivorship and how we transition care for patients who have been treated for cancer at kind of post-treatment. How do we get them like back into the general medicine primary care world? So the overall goal of this talk is really to just think about we could dive into so many different directions of how to care for cancer patients, but I'm trying to just give like a very big overview of how we kind of think about survivorship, and then hopefully a little bit of a framework for how to think about them as a primary care doctor, because that's what all of us do in residency, and many of us do after residency too. So we'll get started. All these slides, most of them have pictures of my dog because I thought that was more interesting than Googling generic photos of people in clinics. So you'll just have to bear with me, and lots of Dover shots. Okay. So I have no financial disclosures. I guess the only disclosure that I can say is the reason I'm really interested in this topic is my dad is a cancer survivor. He was diagnosed with multiple myeloma when I was 8 or 9 years old. And so he went through like many years of stem cell treatments, transplants, and chemotherapy, and has been in remission now. And is at like just reached his 20-year anniversary since his diagnosis. So it's just something like I've been very exposed to growing up, and something I'm really personally interested in, and this patient population really excites me. So really happy to have any comments or questions throughout all this. Okay, so our learning objectives. The first is just to define cancer survivorship and who we really are talking about in that population. The second is to identify components of survivorship and what we want to think about when we are taking care of these patients. And then have a list in our minds of several common physical and mental late and long-term effects of cancer and the treatments that it utilizes. And then finally, just discuss ways of how we integrate this care into primary care, and think about some guidelines and how we can look some of this information up, because it's a lot, and I don't remember all of it, and certainly wouldn't expect anyone else to either. Okay, so the first is, who are cancer survivors? So we'll just start with a quick question. When does survivorship begin? Courtney, you can let me know when we've got a decent amount of people answering.
Oh, well, we're at 70%, so another 5 seconds or so.
Okay.
Tess, can you see the results?
Yes, I can. Okay, cool. So yes, at diagnosis, a mixed review of answers here, but I think there are a number of ways it's defined kind of conversationally among patients, among doctors, but I think technically the National Cancer Institute defines it at diagnosis. And that's, I think, a helpful way to think about it, because it really frames the way we think about everything we kind of do to these patients from the beginning. And I think it just helps get a better mindset of like how this has a long-term effect on people. And then the second question we'll go to is, how many cancer survivors are estimated in the United States? And this is maybe mildly out of date by 2 years, but it's the best we've got from SEER data. Great. Okay, so the answer is actually 17 million. Just to have a sense of how many of these people are in the United States, and I know a lot of us go on to practice outside Seattle. So we'll just move to this first part. So yes, defined as survivors are defined at diagnosis, kind of thinking about all the things that can happen beyond that time. The population has really exploded, and I think that's one of the reasons this is kind of an interesting area to think about. Is it used to be under 3 million, maybe 30 40 years ago. We now are at 17 million. And the SEER data kind of predicts it's going to be at and above 22 million by 2030. There's a lot of reasons for this. The population is aging. We are getting better at treating cancer. So in many ways, the increasing number is a really good thing, because it just means we have more people living with cancer as more of a chronic issue, but just presents a lot of things to think about as these patients kind of get older and move into general medicine care. And then more than half certainly are over age 65. So really in the internist wheelhouse to be taking care of these patients. Younger patients who have had cancer are, certainly a separate population that we have that have like all kinds of distinct needs that we think about. But since we don't see the pediatrics all that often, it's just kind of key to think about the adolescents that then grow up into 20, 30-year-old patients. They also are adults considered, they eventually become adults considered cancer survivors. And just some Washington specific data, we have almost 400,000 cancer survivors in our state. Based on the types of cancer that are more prevalent, breast and prostate and colorectal cancer are usually the top three groups of patients that we have in the survivor population too. So when we're talking about survivorship, what is this term? It's something that really got initially coined in the 80s. A few different people were kind of putting out some papers and reflections on what it was like to sort of graduate from your cancer care. And this one piece was talking about mapping the middle ground of survivorship and minimizing medical and social hazards after cancer. This was kind of the first time it ever got brought up, I think, in like literature pieces in the 80s. And then it took a number of years. And then in 2006, 2005, the ASCO and Institute of Medicine put together this Lost in Transition kind of seminal paper that came out and really started to raise awareness about survivorship as an issue. And this was kind of right around the time that that population number was really growing and our treatments were really rapidly changing. This paper or this report is very long, but it mainly is just sort of calling to mind the fact that as we increase in numbers, we are not kind of providing familiarity with non-oncologists, so primary care, family medicine, internal medicine docs who are then taking care of these patients with best practices or understanding of how to care for these issues long-term. So the goals of the report, this was now almost 15 years ago, was to 1, raise awareness of effects of cancer and its treatment, 2, define survivor quality of care, and 3, address policy needs to ensure access to the appropriate care. The jury is still kind of out on how successful we've been in the past 15 years on some of these things. There's been a lot of progress, but definitely a lot more work to be done. And we can talk about that in a little bit too. Okay, so the first component, there's really 5 components we'll talk about. One is surveillance, screening, and prevention. The second is late and long-term effects from a physical standpoint, then psychosocial standpoint, and then health behaviors and coordination of care. So this first part, and maybe if anyone can just unmute themselves, I think the terms that we use to think about these things is just important because it helps us clarify what we're talking about when we talk to patients about what we're asking them to do and sign up for. So can someone just, if they know, explain what the difference between surveillance and screening and maybe how prevention fits into all of that too? Or in the chat if someone has thoughts.
My understanding is that surveillance is for someone who may have already had a cancer to like make sure that it's not recurring, whereas screening is more like screening is for primary prevention purposes.
Yes, definitely. That's perfect. So surveillance is really talking about the cancer they've already had, and then screening is just like Arita said, kind of thinking about them as they are sort of a person in the general population. Like, how do we still prevent cervical cancer or breast cancer just because they've had leukemia in the past? And I think why this is kind of important is that it's easy to fixate on the one cancer that they have had. And just move to the next slide. So, but 1 in 6 cancers actually are second. I think it's 1 in 6 from the data I looked at, that a new cancer is actually a second primary. So these patients are not without risk for, just because they kind of got struck unlucky once does not mean that it can't happen again. And surveillance is really guided by their oncologist. So really important to get a sense of what is happening from the oncologist side. I think a lot of patients come in with hopefully tied into some kind of oncology care. And just, I think as a PCP, knowing what that looks like and who's taking care of it is kind of the most crucial thing. Like, I don't think we as primary care doctors are ever expected or should be the ones setting the timelines for checking on these things, because it's so variable by patient and disease. But understanding, like, am I the one taking care of that? Is that your oncologist? Have you moved? Do you still have an oncologist? I think all this stuff is just really important to think about and then have a conversation with patients about. And then prevention piece is really just kind of the overall health behaviors and guideline adherence, and thinking about how do we continue reducing this person's overall cancer risk. And some of that is just helping them stay in line with what is their long-term care plan from their oncologist too. Okay, and so there are a few little key points I put in here. There's been a lot of research that shows guideline directed follow-up. So keeping patients plugged into their hormonal therapy or into their the surveillance that they need actually improves when patients are coordinated with primary care. So just kind of, again, plugging that these patients are usually really well served if we can kind of bridge them with their PCPs. So the second, and this is kind of the largest section of this, is just thinking about physical, late and long-term effects. I think the late and long-term effect term, similar to surveillance and screening. Does anyone know what the difference between these two things are?
Is long-term just something that persists for a period of time, whereas late is something that pops up later, having not been there at the beginning?
Yeah, great. Kind of intuitive in the words. Thanks, Alex. So yeah, the long-term effects are things that started maybe when someone was getting chemo, like things like neuropathy can often start when people are getting the treatment itself, and then it persists for a long time. And then late effects are things that we want to think about that can really come up like almost a decade later sometimes, especially increased risk for other types of cancers, or like, pneumonitis or fibrosis after radiation, things like that, that we wouldn't necessarily see right when they got the treatment, but certainly can come up years down the road. And then physical, there are a number of physical long-term and late effects that occur both from the cancer itself and from the treatments that people receive. I think we'll go through a number of them, but I think in my mind, when I try to sit down and think about, like, how are we, I hope that sorry, my grandma is texting me. I hope that's not popping up on my shared screen. Anyway, I think having an understanding of just like the general things that can come up for people, and obviously none of these apply to every person, but really being able to think through if people are bringing up these concerns, if you know that they have a history of a certain type of cancer, then really kind of diving into that with them and considering if it might be related to something that they've received as treatment. Just going to move this for a sec. Okay, so this population is unique when we think about late and long-term effects and like really the physical effects of these things. They have a higher rate of disability. Cancer survivors end up with impaired ADLs and just lower overall health. There's a number of reasons for this, but just kind of thinking through a lot of these things so people can help improve their quality of life. So the first thing we'll think about is fatigue. And again, a lot of these things are really in primary care wheelhouse. So fatigue is something that comes up with a lot of patients, but it's really prevalent in patients after cancer treatment. A lot of risk factors similar to general population: depression, chronic pain, if they've received different types of cancer therapy, so more than just one thing, that can be an increased risk. And then chronic comorbidities. Whenever you see patients for your wellness visits, or if you see them once a year, really just screening them and checking in, because there's a lot of reasons why they can have fatigue. And if they are experiencing it, it can impact a lot of parts of their life. So just taking a pulse on how they're doing. Exercise programs, sleep interventions, and CBT have been part of some of the guidelines that do exist now about fatigue and cancer care. Chronic pain is another really serious issue that I think as patients move from acute cancer to like chronic cancer issues is something we really need to start thinking about. It's in 40% of cancer survivors report having chronic pain. A large piece of this is neuropathy. That's a major source. There's a lot of thought and work into like how to better treat this and how to better prevent it. At the moment, they're like duloxetine and some of the SNRIs can be good options. But thinking about the different types of pain, there actually is a great guideline, I think on ASCO's website about neuropathy management and how to think through that with your patients. So if you ever have a patient who has this issue, kind of considering looking that up and taking a read through it. Similar to other chronic pain, just kind of focusing on function, utilizing multimodal approaches. And then opiate use is another important thing to think about. So like I was saying, these patients often are, moving from acute pain where they appropriately are getting a lot more pain medication, but that has been shown to really persist even 10 years after diagnosis. A lot of these patients end up with higher pain medication prescribing, which may or may not be appropriate, and just kind of in the light of thinking about the opioid crisis and how we kind of give, counsel patients through this and include their families and other, resources. I think it's just important to not to forget that these patients, just because they have a cancer diagnosis, are not susceptible to all the other pieces that go along with this. Cognitive effects is a big piece that I think is definitely in need of a lot more research, but there are obviously things like if you have a primary CNS malignancy or you've had treatment that's affected your brain, that certainly can cause cognitive effects. But chemo brain is this kind of vague issue that has not been super well understood, but is reported in almost about two thirds of patients who have had chemotherapy. So it seems like it's something people are experiencing. It's just we don't have the tools that like really appropriately define and diagnose it at the moment. So there have been some reports that recommend cognitive rehab and occupational therapy for these patients, especially if it's impacting their ability to work. Cardiac and pulmonary toxicity, again, just keeping in mind if your patients have gone through certain chemos or radiation, they can be at risk for, and I should say immunotherapy as well, they can be at risk for a lot of these longer term issues. Cancer survivors have a higher risk of both risks to worsen cardiac disease and higher risk of cardiac disease itself. And then among breast cancer patients, cardiovascular disease is actually one of the leading non-cancer mortality causes, which is not super surprising, but a lot of these patients end up, having these become their main issues at end of life. So thinking about radiation and chemo, this can cause, I think anthracyclines are sort of one of the major culprits for causing cardiac disease down the road. And then radiation and chemo can also cause pneumonitis, which can lead to fibrosis. So if patients come in with shortness of breath and they have a history of cancer, just really thinking through like, okay, what did they receive as treatment? Could this be related? And working, we don't necessarily need to work this up in a super unique way, but just kind of using this as a trigger for, kind of diving into things and thinking about their history. Endocrine disorders are really common as well, especially people who have had radiation. They can have an increased risk of diabetes. There's also an incredibly high prevalence of thyroid disorders after lots of different types of cancer treatment. And so like you would for most patients who come in with fatigue, but specifically for this population, always being mindful of checking a TSH and just keeping in mind that that can be a very common issue for people. And anyone who's received immunotherapy, as you would imagine, can have a lot of endocrine disorders as well. Bone health is a major issue it's something that we have a little bit more data about, mostly because a lot of survivorship research started in the breast cancer population. And so we know a lot more about this, I think. But patients who have had cancer and have had treatments that include steroids, radiation, any kind of hormonal therapy. So people who have had prostate cancer and have been on androgen deprivation as well. People who are in premature menopause from chemo or radiation or any kind of surgery as well. All these people need to have bone health at like top of mind thinking about as well, because they develop issues with bone mineral density and osteoporosis at a much earlier stage in their life than you would think otherwise. And I think another key thing to think about with bone health is that if people are having issues like pain that feel like bony pain, that is not an osteoporosis concern. That is like a get them, sort of back to their oncologist and reconsider if there's a concern for metastasis. That's not something where we're like, okay, let's get a DEXA. That's more of a kind of a more acute issue. Lymphedema is something that we've gotten a lot better at preventing, especially from a surgical perspective, but still things that come up for a lot of patients who have had surgery, especially, and radiation too. But and anything that really disrupts the lymph drainage, but it can be really painful and can just cause problems with people being able to work and exercise, and can lead to infections and chronic pain as well. There's a lot of great therapy that people can get if they are able to get access to it with certain PTs. I know there's actually like a lymphedema specialist, I think, that within physical therapy who work with patients at the SCCA. So if this is an issue for patients, just trying to get them referred to the right people. And again, like early recognition, really important before it becomes more irreversible or more chronic. Bowel and bladder dysfunction. A ton of different things that can happen if people have had colorectal or pelvic cancers or surgery or radiation. Really a laundry list of symptoms that people can have. But I think instead of diving into all of these, just to suffice to say that if your patient has had a history of colorectal, any kind of pelvic or abdominal involved cancer, really thinking about when you see them annually, when you see them for wellness, or if they bring other issues up, that they should be screened for these concerns and really referred out to the specialty care that they might need. A lot of patients need things like pelvic floor therapy, which is something that we have here at UW too. It's kind of a long wait to get in, but a lot of patients benefit from seeing people like that, or going to GI or GU specialists to sort of talk through any issues that have come up after this. Sexuality is a really, and sexual health really is kind of an undertreated issue for these patients. If you kind of think through all the different things happening to patients throughout their cancer life course, their anatomy often changes depending on what surgery they've had. A lot of people are on steroids or hormones that affect all kinds of things, like their actual sexual function, or it can cause pain, and just their libido in general. And intimacy also changes a lot when people's roles within their relationships is changing when they're in the midst of an acute or chronic disease. So a lot of this is like a very common issue, 40 to 100%. Obviously, very really wide range here, but a lot of studies have kind of shown this is super common, and not even close to half are treated. So assessing early and often, and then trying to get people referrals into pelvic PT, like I was mentioning, is really great if people are having issues with that, with pain, and then or to seeing a gynecologist if they or their you as their PCP can help manage if they're having dryness or erectile dysfunction, or any kind of like partner therapy, just to if that's something that they are able to access as well. Premature menopause, similar to the bone disease, just something to think about, and then kind of thinking through it's really the same things that you would think about for anyone else with menopause, but just understanding that this can happen a lot earlier for people. So it's not just our 50-plus-year-old women, but really thinking it could be as early as like mid-30s or 40s, depending on when their treatment was. Infertility is something we won't really get into too much, just because we usually are not the ones having these conversations, but kind of drives home the point that thinking about survivorship from day one of diagnosis is super important. Okay, so psychosocial late and long-term effects. A little bit shorter, but can just maybe in the chat, or you can unmute yourself, but what are some of the psychosocial issues that kind of come to mind for this patient population?
Tess, there are a couple things coming in the chat now. Depression from serious illness, worry that every symptom is cancer representing, anxiety about recurrence.
Great. Yes, all those things are certainly true. So the mental health of patients after cancer and cancer treatment is a major issue. And I think something that from a survivor patient perspective is something that gets kind of dropped. I think a lot of people in various studies kind of report they feel like they get all of this intensive tucked in care and support and many people seeing them and talking to them while they're getting treatment. And then they finish their active treatment and sort of get released into the world and can feel a little bit uncharted in that time. There have been some interesting studies that have shown depression rates are really not too dissimilar for these patients compared to the general population, which is encouraging. But anxiety rates are actually higher in both patients and in partners of those who are cancer patients. So definitely something to screen for and think about when you see patients. People who have depression and anxiety have been shown to have worse cancer outcomes. And though depression may not be that much higher, the people who do have depression, I think, are a little bit, at least from some studies, we've seen that they have a higher rate of suicide for cancer survivors. So just taking these issues really seriously and thinking and talking through them with patients. And there's also been a lot of work done to show that patients who have a fear of recurrence or issues with mental health really have problems with, not all across the board, but have a higher risk of poor compliance or poor follow-up and staying plugged into care. So certainly something to think about as your primary care role in keeping these patients plugged in. And this was just a study that found only half of the patients who had some kind of mental health distress were actually receiving mental health treatment. Certainly mental health treatment is access to that is sort of an issue across the board, but I think just keeping in mind these issues for these patients. And then social role adjustment is something we talk about a lot within this community. And then thinking about, people who either are parents or were working or were sort of a caregiver in any way, how that role can kind of reverse, and just giving patients like the space to acknowledge that that's different. And if they need support from social work or occupational therapy in any way to talk through like how to re-engage with work or with their partners or what, any of those things. I think just important to acknowledge that these things are like major life adjustments for people. Really that happen a lot after their treatment, because in the moment they're really focused on the disease, and then sort of in the months and years after that, kind of readjusting to these roles. Financial toxicity is something I wanted to make sure we mention. There's been a lot of great work by a group at SCCA looking into how the cost of cancer care can really negatively impact patients and their families, not just in a kind of financial way, but in a medical way too. There have been a number of studies about how insane cancer care expenses can be, but these patients frequently report that they go into debt more, they file up for bankruptcy more often, and these things have been shown to be issues for patients then foregoing medical care, which is very understandable. And they also are at higher risk for worse mortality down the road. So again, if this is thought to be, kind of thinking through this with your patients and keeping it in mind when you talk with them, and getting them support from financial services or social work when we can is really key. Okay, and then the next part is super in the primary care wheelhouse. So thinking about that prevention piece and how we consider, how do we help people transition after this treatment phase into a sort of lifestyle that can help reduce their risk of recurrence and risk of cancer in general. There's been a lot of study and research into how weight and obesity plays a role in cancer. I think it's really tricky when we talk about weight, especially when we talk about weight with cancer patients. I think weight gain has been shown to be a really common side effect of cancer treatment. I think we often think about like weight loss in the midst of like an active chemo session, but I think a lot of patients do gain weight during and after treatment. And And, you know, it's tricky because we don't want to make it seem like, you know, they've done something, patients are doing something wrong, or that this is like sort of the most important focus. But I think at least acknowledging it with patients and sort of talking through this issue with them, mostly because the risk for metabolic syndrome is increased in patients after cancer diagnosis and care, regardless of their weight. And then they also have a higher risk of weight gain. So when you couple the two together, people can just be at higher risk for all the cardiovascular issues that we kind of know and talk about already. And I think just using, there have been some studies that show that this transition point between active cancer treatment and then sort of back into some semblance of normal life is really like a pretty highly motivated time, and that people often can more successfully integrate nutrition and exercise habits into their life when they're talked to about these things by an oncologist or by primary care. So you certainly can play a role in that as well. Smoking and alcohol, not bringing up anything groundbreaking here. Smoking, obviously want to work on smoking cessation with patients as we can. There's no unique piece of smoking cessation with cancer patients than from the general population. But just thinking about things like alcohol as well, can, you know, maybe just trying to, when you do talk to patients about this, if it is an issue, a lot of people find that within their kind of cancer journey, there are a lot of like these teachable moments where people can kind of link, you know, you made it through this issue, but alcohol can actually worsen your risk for breast cancer, morbidity, mortality down the road. And so kind of finding these key issues to talk about with patients is sometimes really helpful. Okay, and then the final piece is really coordination of care, which is something I'm super interested in. And I think we need a ton more work done in how we actually deliver this care. I think there's a major issue for access and equity for this space. I think, as you probably have heard, a lot of these things I'm talking about, you know, the answer is often that we need to sort of resource out to different specialists and referral to, you know, social work and mental health providers. And I think that's all wonderful when we are in a place like here where we have access to a lot of those people and a lot of those groups. But I think being mindful of the fact that this is not always accessible to people, because even if they do live around here, insurance coverage can be really problematic, and the cost of this care can be really challenging. But especially for people who are not here, like if we think about kind of our greater WAMI region and more rural areas, there is not really a lot of access to therapy specifically focused on sexual health and like partner therapy. So I think there's a lot more work that needs to be done. And I think I'm really hopeful that as we've, especially in the past couple of, year and a half, as we've exploded a lot of like telemedicine and access to care in some more remote places, that hopefully this can help improve some of these things too. But I just wanted to put a plug out there for some of the guidelines that do exist. As I mentioned back in 2005 or 2000, I think it was 2006, but when they put out this report, there really were no guidelines at all. Like you could not find as a PCP, what should I be doing for my breast cancer patient who's coming to see me for a wellness? And so one of the great things that's come out of that is that ASCO, NCCN, and ACS, or American Cancer Society, they all have some guidelines that do exist, and you can really just Google these group, ASCO survivorship guideline, and you can pull up a few of them. They're, I think, the starting point. They're not really as comprehensive or as detailed as I think we're all kind of hoping to get, but at this point, a lot of it is based on expert opinion. There are not a ton of randomized controlled trials for all these things yet, hopefully more to come. But I think it's just nice to know that these exist. So just so people kind of hear about them, ASCO has a guideline for depression and anxiety symptoms within cancer patients. I think they have a neuropathy focused one as well. There's a fatigue guideline. And then ACS has some really nice guidelines on some of the more common cancer groups specifically. So there's a guideline for breast, I think it's breast, prostate, colorectal, and head and neck cancer. So which is why, we don't need to dive into like all the details of all these things, because, everyone's patients have different issues. But I think if you see a patient on your list coming into clinic to see you, or if you, meet a patient and you find out this is in their history, it could be nice to just pull up one of these guidelines in your, as you're kind of wrapping up with the patient, and just maybe think about setting up a visit to do survivorship care planning with them, and making sure that you're talking through these issues. Within the coordination of care space, I think a lot of people wonder, like, does this get owned by oncology? Is this owned by primary care? Who is really like driving this train? And I think it's really hard to know. And it really depends on the patient, on the practice setting, on the provider, if the patient's still connected to their oncologist. I think a lot of people feel really, really tied into their oncologist. And so it's hard to take that leap into trusting the next person, because this person, the oncologist, has been with them through a really pivotal point in their life. But I think at this point, there's a goal that patients do graduate from their cancer therapy with this survivorship care plan. I think the jury's still out on exactly how useful these are, or if they really change care, but it's something that a lot of PCPs had been asking for and sort of pushing for. Like, if you want us to take care of these patients, and a lot of like studies show that PCPs are very eager and willing to do that, that there just needs to be clear guidance on, okay, if I see them in clinic, am I ordering the mammogram? Am I ordering their tumor markers? Or is that something that the oncologist is doing? It's not common that people actually receive survivorship care plans yet. I'm hopeful that that starts to change. But when people do receive them, there's been a report where 9 times more likely to discuss survivorship needs with their patients, which is sort of not surprising. But I think I think the key is really, wherever you're practicing, whether it's here in Seattle, here at UW, or if you're graduating and going on to work somewhere else, really having a sense of like who's in your network, who's in your neighborhood, and what the system is there. And if you have a patient who's kind of coming to you from cancer care elsewhere, understanding like how to get their data, how to get their oncologist kind of involved, and even just a brief conversation about who's managing what is super, super important. There have been a lot of different assessments of what kind of models work best. And like I said, there's no perfect system as of this moment, but I think there are some where in an academic center like UW, where there's a lot more, there's more of like a cancer home and a survivorship center, and there's more multidisciplinary care accessible. These patients often kind of straddle like oncology and primary care. There are some models where there's a PCP like embedded within a cancer care center, which I think has its pros and cons. There's a lot of different things that exist out in the community. So again, wherever you end up practicing, just kind of helpful to get a sense of the lay of the land and who is kind of directing this care in that space too. And just to drive home the point, cancer care and long-term follow-up and long-term staying within guideline care and surveillance care has been shown to improve with the involvement of primary care in survivorship. So though it's messy, and though we don't have a lot of great options at the moment, or we don't have a lot of clear perfect systems at the moment, I think just trying to keep primary care docs in the mix of this conversation is super, super important. And so just some future directions. I think we're starting to think about cancer more and more as a chronic disease, and hopefully that can start to frame how we talk about caring for these patients long-term, much like we do for cardiac disease and diabetes and arthritis and all these other issues. Hopefully moving towards improving communication between primary care and oncology. We need more research for sure into how to treat some of these really common issues that come up after treatment. And then I think another major issue is just thinking about adjustment of how we transition patients, and if that's something that is valued and paid for when patients are having visits, to discuss these transitions between oncology into primary care is certainly something that's been talked about a lot too. I feel like I was giving my dog a lot of credit, so I had to toss in a picture of my cat too. But thanks so much for your time. And I would love to hear any questions or comments or thoughts or experiences people have had too in the next couple minutes before I know we'll take a break.
This is just a general comment. I don't know if anyone else has had this experience of now being someone's PCP and then going to an oncologist and getting certain recommendations and then saying like, wait, well, I want to talk to my PCP about this, about where to go from here. I'm feeling like, wow, like that's great that they trust me, but also like, wow, I have to now interpret this data and help inform these person's decision about treatment. And yeah.
Yeah, no, that's a great point. And I think one thing I would plug is that if people are kind of trusting and having coming back to see you, that's really awesome. A lot of times I feel like PCPs feel the opposite, where people are like, oh, I can't do that until I talk to my oncologist, which is understandable. But if there are questions about some of these issues, there is a survivorship center or a survivorship clinic at SCCA. It does like a very diverse set of things, but if patients ever come to you with these kind of questions, or if they come up without, if they weren't taken care of at SCCA, if they like had an oncologist and then moved to Seattle or something like that, and they don't have a survivorship care plan or anything like that, it's a resource where like we could potentially reach out to them and see if they would see the patient and kind of put together some semblance of a plan and guideline for the patient too.
Awesome. Thank you so much,
Cool.
Tess. I don't know if you can see it, but a lot of praise in the chat for you and what a wonderful talk this was today.
Cool.
Since it's 9:45,